Greetings, students, and welcome to International Healthcare Policy 2024, spring of 2024. So we'll get started with our first lecture in just a minute here, but a few things I wanted to bring to your attention before we get started. So number one, how the presentations work in this class is that there are quiz questions embedded along the way, and because of that, you cannot fast forward and you can't skip ahead. So make sure that you have set aside enough time to go through the entire presentation in one sitting. I mean, yes, you can pause and walk away, but I wouldn't try to exit completely out and then come back because sometimes it makes you start from the beginning and that can be frustrating. So that's number one. Number two, for some reason, I'm not sure why, Kaltura and Canvas do not communicate very effectively or immediately. So sometimes you'll submit your quiz at the end and it takes 2 to 3 days for it to show that it's been completed in Canvas. So just know that once you get to the end of the quiz presentation, if you've hit submit, it's in the ether. It will eventually show up in Canvas. I promise. I promise. I promise. So without further ado, let's get started with this first lecture. We're going to talk about the historical development of U.S. healthcare policy and, how we got to where we are today. Here are our learning objectives that we give you at the beginning of every lecture so you know where we're going. So this one's about the historical milestones along the way, the importance of urbanization and physician development and how that influenced healthcare delivery and healthcare policy in this country. We're going to evaluate a few attempts at U.S. healthcare system reform, the good, the bad, and the ugly, some attempts that did fail. And we're just going to, on a very base level, introduce the nurse's role in policy because we're going to focus an entire module in the near future on that role. So we really just touch the surface of it towards the end of this lecture. So we're in a healthcare policy course where we have students of multiple different cohorts and ages here. It seems, it might seem a little basic to be defining policy in and of itself, but I think it's important to have that in the back of your mind that this is what we are here studying, and that the nurse's lens is the purview through which we are studying it. So we're looking at authoritative decisions that are made that are either legislative, executive, or judicial that are intended to direct or influence actions, behaviors, and decisions of others. And decisions to some people sounds a little bit, a little bit off. Like how can you influence the decisions that I'm making? And it's because healthcare policy in particular, we are trying to, in the population level, make healthy behaviors the default pathway. So that's part of how we're influencing decisions. And those are, when we talk about those authoritative decisions made in the branches of government, those are the ones that can have some legal and financial consequences to you not following them. The other type of policy are those decisions and guidelines that direct behavior either in the private or the public sector. So we're really talking about hospital environments, organizational environments that don't have legal consequences if you don't follow that behavior, but still have consequences to the individual. So I have this quote in here from Abraham Flexner, and he is the author in part of what's called the Flexner Report, which we'll talk a little bit later about. This exerted a significant impact on the growth of North American biomedicine, and we can't talk about the development of policy without talking about the development of a more homogeneous education system, because without it, you don't know what a doctor is, you don't know what a nurse is, and we can't become the trusted professions we are without developing those rigorous academic programs and without developing those cultures, those professional cultures. So we're going to start by talking about medicine in general. There's no healthcare policy without it, and the practice of medicine, loosely we'll call it, it's been around for thousands of years, right? So in the beginning, the practice of medicine was very unscientific. By the time we get to the forming of America in the 1700s, It's much more leaning towards evidence-based practice. Not quite there yet, but much leaning towards it. So in the 1700s to 1800s, roughly 1760 to 1840, for those of you that remember back to your history days, I am talking about the Industrial Revolution and urbanization. So urbanization is what brought large rural populations flocking into the cities for work. And they were coming into the cities faster than the cities could keep up with the infrastructure to be ready for them. And with that brought the influx of communicable diseases, because you have these large populations that are in close quarters that aren't, so shall we say, the most sanitary of conditions all of the time. So this posed a very big problem. How do we stop the outbreaks? How do we take care of the people that are suffering from these communicable diseases? And that's what gave rise to the first hospitals in this country. They were called pest houses, pestilence houses, plague houses, fever sheds. And you went there for palliation, right? We weren't always sure that you were going to come home. In fact, a lot of the times you didn't. So there's a drawing there of the first one. That's Bellevue Hospital, which is the oldest hospital in the United States. At least they claim to be. It's been disputed, but they claim to be. So here we have, and I don't think this is in the slides I had you print out. This is for all those interested in some local or semi-local history. So this is a picture of Metro Health. I believe it's from 1837, and this was a poorhouse, which was a combination homeless shelter and pest house. And for some perspective, Akron City didn't have anything even remotely similar until around 1892. It was still a growing industrial city at that time. They had a smallpox outbreak, and that's when they built their first pest house. So another side effect, haha, pun intended, of industrialization and urbanization is that because the population was now much more dense, physicians were closer to their clients and could see more of them. So they did just that, and they started working longer hours, and the practice of medicine starts to become lucrative. The other thing that happens around this time is that women enter the workforce, but not at the same level as the physicians do. But it's important to note that industrialization did roughly coincide with the rise of the modern American school. So once your kids hit school age, the woman is now free. She's not stuck in the home anymore, like she was for quite a bit before then, generally speaking. So I have the University of Pennsylvania pictured here, because they were our country's first medical school, even though you weren't producing MDs at that time. But this is where it starts. They have their first class was, I believe, in anatomy. And then it develops over the years. And you're getting this scientific base, right? And you're becoming more evidence-based instead of snake oil salesmen. And that leads to an accumulation of public trust that gives you cultural authority, that sense of legitimacy that grants you autonomy as a profession and the ability to self-regulate. That trust was critical to the expansion of healthcare as a profession and the growth of hospitals and other medical and medically related institutions like the universities that train those medical providers. So these huge institutions are born out of that. At this time, there's also that very big, that line separating public versus private. So I've already mentioned poor and pest houses. That's your public. And then you have proprietary hospitals, which are owned by physicians, that the patients have to have the ability to pay in order to go there. Those are proprietary hospitals. And that's private, of course, and then another version of private were the university-based medical centers. So you didn't necessarily, if you couldn't pay, they would help you pay, because a lot of it was educational and students were there. So those are our very early days. Alrighty, so here's the Flexner report that we're circling back to from the quote at the very beginning. So Abraham Flexner was not a physician, but he was educated in the natural sciences at Johns Hopkins University. he was keenly interested in medical education in the United States and Canada, and he visited all 155 schools in North America. His report for the Council on Medical Education provided a framework for modern medical education, and it introduced a number of educational principles that are still in use today. The Flexner Report found that the United States had too many medical schools and that too many physicians were being trained as a result, and there was too much variability and the public wasn't protected. So that report was published in 1910. It called for a restructuring of medical education, the consolidation of medical institutions, and a greater standardization of curricula. All good things, for the most part, right? Except I'm going to make a comment here on structural racism before we move on. So the report contains 2 pages on Black doctors, and he suggested that Black students should be well trained to offer a limited scope of medical care to Black patients only, and he emphasized that the Black physician's duty was to keep African Americans healthy enough to not contaminate nearby white people. So that was, that has huge ramifications for African American doctors because it shut down all of their med schools, and we are still dealing with those ramifications today. There have been a couple of articles published on what our response should be to that, and a movement to try to rectify the ramifications of the Flexner Report on African American physicians. But I must admit I haven't read all of that for right now, lack of time, and number 2, it's in the physician world and not in the nurse world. So we'll move on from that. Shout outs to Johns Hopkins. They were the first med school that established entrance requirements for medical students. And they developed scientifically based curriculum that incorporated clinical and medical rotations. They were the first to do that. They were also the first to admit women and the first to successfully implement cardiopulmonary resuscitation. Oh my God, where will we be without that, right? So the Mayo Brothers, another huge system to talk about because of their model of what a collaborative practice looks like and salaried physicians. And what I just want you to do is take a minute to think about what a salaried physician means versus, not means, but what's the significance of it when you compare it to a physician that is either being paid per patient, which would be volume, or by the hour. So I'm positive that you've all heard of the Spanish flu. Especially in comparison to the COVID-19 pandemic. But I can't stress enough how important this milestone was to the development of healthcare policy and public policy. Can't stress that enough. Of course, we lost a lot of Americans. We lost 675,000 Americans. That's more casualties than World War I, II, Korean War, and Vietnam combined. So it was a devastating loss for us. And because of that, it led to an increased emphasis on public health and epidemiology, which was still in its infancy at that time. But the second really big development is that we understood as a healthcare profession how bad we messed up. We messed up in our communication, in our education of the public, and how we handled it from city to city, state to state. So it really united the profession in how to mindfully communicate with the public. All right, so before we move on to talk about the major healthcare reform attempts in this country, we'll talk about healthcare delivery mainly by talking about insurance plans. So providing care for the sick and dying has always been part of the human experience. The problem with where we are today, especially with industrialization, is how do we pay for it? It becomes exceedingly more difficult because the financial cost of medical treatment was rising. So that's what gave way for the need for any kind of payment model or insurance. And there's a big difference between what developed in Europe versus what developed here in the United States. So this is, and I think I even took it out of my objectives, but we do need to understand that there is a path dependency issue that we're having here with how our healthcare system arose. And let me explain. So prior to World War II, Europe was a leader in healthcare delivery, research, and education, number of well-established institutions, but everything was literally blown up. So when Europe reemerged from the conflict, it had to create new healthcare systems. Those systems were significantly different from what had developed in the United States, because from the beginning of those systems, because of the devastation that they went through, they considered healthcare to be a right and not a privilege that you could only have based on where you worked or how much money you made. So the typical market approaches that we were using over here, they were greatly de-emphasized in Europe. And again, it didn't have anything to do with we don't like the United States and we don't want to be like them. It was because of what had just happened to them and to their population over there. That the organization and funding of healthcare services was treated as a collective responsibility between the government and the people. Stark contrast between them and here, right? So it starts off in this country very much dependent, healthcare delivery and insurance, by the way, it's in this country very much dependent on who you know, where you live, and where you work, right? So it started as sick funds. That's just as it sounds. Everybody that's working for the same employer puts a certain amount of money into the pot, and when somebody gets sick, breaks a leg, whatever may happen, then you can withdraw funds from there for a variety of reasons. Workers' compensation, of course, we all know that's pretty similar to that, and that dates as far back as the Civil War. So Blue Cross versus Blue Shield. So this is the very, very early days. The first true insurance began in 1929 at Baylor University Hospital in Dallas, Texas. Around the start of the Great Depression, the hospital was facing some serious hardships. Baylor University Hospital, that is. And the administrator of that hospital enrolled all Dallas public school teachers in what he then called the Baylor Plan. Long story short, too late, I know. For 50 cents a month, the administrator, Dr. Kimball, promised up to 21 days of care in Baylor University Hospital. And by 1933, that concept had spread. Plans that grew out of that model became known as Blue Cross plans. So that's hospital services. So now we'll talk about Blue Shield. The first medical service plan to cover physician services was established in 1939 in California, and that paved the way for the development of Blue Shield plans. Blue Shield plans offer free choice of physician, and they were endorsed by the American Medical Association. These plans were indemnity plans, which is it's a type of payment where the patient pays for the services to the physician, and then they are reimbursed by their insurance. So again, indemnity is patient paying for the services and then they're reimbursed. So not my favorite. It's problematic, if you ask me. Commercial insurance is just as it sounds. Commerce equals buying and selling, and that's on a large scale. So commercial insurance is buying and selling products on a large scale, and that product is hospital coverage. So this begins in 1934. Physicians hated commercial insurance when it sprang up. And the American Medical Association made several statements against it. They were very skeptical about direct contracts with insurers, and they had concerns about the complication of payment arrangements. Those concerns remain mainly because we let the government be the middleman in between insurance and physicians. So it is still problematic, to this day. Medicaid and Medicare, I do an entire other module on that, so we'll talk about that later. And prepaid plans are just as they sound. You are putting so much money in directly to an insurer in order to get whatever services you're looking at. Physician services today would include lab services and stuff like that, but we don't have I don't think we have any prepaid plans left. I will look into it, but I'm pretty sure we don't offer those anymore. So I'm just going to define for you here some of the health, well, not some of them, all the health insurance products that you will hear about throughout your lifetime as a practitioner. Health maintenance organizations. This is a type of insurance plan that usually limits coverage to care from doctors who work for or contract with the HMO. It generally does not cover out-of-network care except in an emergency. And the reason why I say usually is because of what's happened recently with the No Surprises Act. So the example of where this fell short is if you went to a hospital to get a procedure done and that hospital is in network, your physician is in network, everything else is in network, but say an anesthesiologist comes in and provides care and they are not in network, well, then you're going to get hit with their full bill on top of what you've already paid. So that's what was problematic with the health maintenance organizations, and you're no longer allowed to do that, by the way. Managed care plans. These are risk-based plans, and you, as the provider, will receive a fixed prepayment per beneficiary per month to help pay for the cost of all the covered services that beneficiary may use. So it's the insurance company determining, let's say you have type 2 diabetes and they're expecting you to visit your physician so many times per year, and you're going to get an A1C done and blood work done and yada yada yada. They're anticipating what the cost would be and then sending an amount per month to those providers to hopefully cover all of the services. So I think you can kind of see the problem there. And then narrow network plans, they're actually very similar to HMOs. It's just that the focus is narrow, they're smaller. All right, so a few more terms here before we get to our healthcare reform. PPO, Preferred Provider Organizations. Again, just like it sounds, it's a health plan where you pay less if you use providers that are in the plan's network, preferred. You can use doctors, hospitals, providers outside of the network. You don't even need a referral. It's just going to cost you more. And they usually spell it out how much more. The point of service plan is the type of plan where you pay less if you use doctors, hospitals, or other healthcare providers that belong to the plan's network. You have to have a referral from your primary care provider in order to see anybody outside of network or in order to see a specialist. So that's the big difference between the PPOs and the point of service plans. And then the high deductible health plan, these are also known as consumer directed health plans. What is good about these plans is that the monthly premium is usually lower. The problem is that the deductible is so high that sometimes in case of catastrophe, it can almost bankrupt you depending on how high the deductible actually is. But a lot of people like it because they don't want to pay too much per month. And then conventional insurance, you'll hear, if you've not heard about that before, this is insurance that you are like life insurance, or you are insuring a portion of your body. Like, so if you're a model, you're going to insure your legs. If you're a hand model, you're insuring your hands. That's conventional insurance. So here we are going to talk about healthcare reform. But first, I want to talk about a bill that didn't pass. So the bill that did not pass was the American Association of Labor legislation. And this was a bill that was drafted in 1915 by a group of economists. They drafted this bill that provided for physician and nurse services, sick pay, hospital benefits, maternity benefits, and a $50 death and funeral expense for workers in the United States who earned less than $1,200 per year. The bill called for the cost to be shared by workers, employers, and states. So keep in mind, this is 1915. We would be so much better if this bill had passed in the first place. But it represents a major step forward in the progressive view of healthcare and social welfare. And it basically, kind of initiated the fight that goes on today, right? About trying to prevent disparity. The next thing that happens in these early eras of attempts at healthcare reform is the Committee on the Costs of Medical Care. Now, this wasn't legislation or anything. It was literally that, a committee. In the 1920s, Congress was already concerned with the rising costs of healthcare, which blows my mind because this is over 100 years ago and nothing even remotely, happened with tech advancements at that point. So they're already concerned with the rising costs. That they formed this committee, and in 1932, that committee recommended 6 principles for healthcare coverage. Number 1, safeguarding quality of service and personal relationships between physicians and patients. Very important. Number 2, providing for people's real medical needs, which means eliminating unnecessary surgeries and procedures. Number 3, providing service on financial terms that allow a majority of people access to services through individual and collective resources. Again, trying to be proactive and prevent inequities and disparities. Number 4, shifting the emphasis from cure to prevention. Number 5, by the way, that's my world, prevention. Number 5, allowing for the selection of competent practitioners. And 6, providing adequate payment to practitioners and agencies. The American Medical Association did not like these recommendations. They published a statement calling the recommendation and the committee socialist and anti-American. So next we are going to talk about the Wagner-Murray-Dingle bill. I don't know why I can't say that without laughing. And I'm not even going to edit that out. This is another bill that died. It called for the inclusion of medical care as an improvement to the current Social Security bill. Even though it died, I mention it because it sparked a serious debate that led to Medicaid and Medicare. For the next bill, the Hill-Burton Act, I think that the book downplays this act. Hill and Burton were political opponents, not as polarized as some of political opponents here today, but they were political opponents that came together and could agree on hospitals needing to be more inclusive and to try and eliminate some of the disparities that they saw that were rising. You can refer to the Ohio Capitol Journal printout. It talks about the creation of the act in more detail. And it's Ohio Capitol Journal because I think it was Burton that was from Ohio. One of the two was from Ohio, senators. But anyway, in 1975, 1/3 of our nation's hospitals were funded by this act. We're now down to about 22% of hospitals being publicly funded. So they called for public funds, and you had to meet 3 criteria in order to receive those funds. Number 1, you had to offer care on a non-discriminatory basis. So this, again, significant because it predated major civil rights laws. It did, unfortunately, allow for separate but equal facilities and hospitals receiving funds. So after the Civil War era, that was gotten rid of. Number 2, you had to be able to offer free services for those who could not pay. And number 3, you had to prove economic viability. So Hill-Burton would require matching funds from state and local government. They didn't want to be pumping funds into hospitals that were obviously either failing or going to fail soon. Pardon me. Dang it. Again, I won't edit that out. Medicaid and Medicare legislation. This is way too huge to talk about in a tiny little snippet here. I go into much more detail about that in the financing module. So in September 1993, the Clinton healthcare reform era begins. And I was a freshman in college, and I don't think I really understood the gravity of the situation of what was happening, of how large of a healthcare reform they were trying to make at that time. So for those of you who were like me and didn't really remember, I'll go over it for you right now. Clinton's proposal stated that every citizen would have a health care card entitling them to treatment and services. The plan would require that every citizen and every permanent resident of the United States be enrolled in a qualified plan, either individually or through a business, and that should sound pretty familiar to you because that is part of Obamacare. All businesses with more than 5,000 full-time employees would be required to offer health insurance, and subsidies would be provided to help offset the cost to individuals, including 100% subsidies for people with low incomes. In other words, it's free. All states would establish regional health alliances, which everyone would be required to join, and the alliances would purchase insurance for the residents. The alliances could set fees for doctors charged on a fee-for-service basis, and the federal government would provide funding for the administration of the plan. So you are merging a market-type approach, which is the fee-for-service, with the government providing the funding for administration. The federal government would also fund insolvent state programs, and long-term care programs. And the plan would also have created a national health board to oversee the quality of healthcare services. They really were cherry-picking some things out of national health systems and other models to try and merge and help us do better over here. Of course, unfortunately, that reform initiative failed, but what did pass was the Children's Health Insurance Program, and that provides health insurance to uninsured low-income children who are not eligible for Medicaid. So the next reform era came with George W. Bush, and if you just think about it, just think about Part D at this point. It was called the Medicare Prescription Drug Improvement and Modernization Act, but really focus on Part D. So D as in the prescription drug coverage and D as in donut hole. So the donut hole was a lot simpler in George W. Bush's days with that initial act. It was when you were spending in between $4,020 and $6,350, you were responsible for paying for your medications in that donut hole. And then once you got over $6,350, they considered that catastrophic coverage and everything was paid for. The problem with this is most people are hitting that donut hole late in the year and they're stuck in the hole, right? So it's not exactly the best way of cost sharing for prescription drugs. So when the Affordable Care Act was passed in 2010, it originally included a gradual closing of that donut hole. Things got super, super, ultra complicated. I'm not even going to go into it all. Where we landed within the last couple of years is that once you've spent $8,000 out of pocket, then you enter the catastrophic coverage period. It's irrespective of any kind of donut hole. And then you are only responsible for paying 5% of the cost of each of your drugs after that time. In 2024, the cost sharing requirement was waived because of a provision in the Inflation Reduction Act. So whether or not that comes back in another couple of years, I'm not sure. But for right now, that is waived. So after $8,000 a year, everything is covered 100%, thank God. So now we are almost up to today, right? I still can't believe this was 14 years ago when this was passed, but 14 years ago it was. The Affordable Care Act. So, first of all, individuals and businesses were mandated to buy and provide coverage for their employees. The government provided subsidies to assist in that effort. And second, the law included a very popular and long sought after provision that would guarantee the issuance of insurance. There were measures to prevent exclusion on the basis of pre-existing conditions. And then finally, certain preventive services were covered at 100%. So what I want you to do is, and I'll say this now, you'll be reminded and prompted later, is to just do a simple Google search, impact of the Affordable Care Act, and you'll find multiple articles, some of them anecdotal, but a lot of them actual research, and just write a 3 to 5 sentence summary on what you found when you took a look. Impact of the Affordable Care Act. And finally, we're going to talk about just a few more of the reform eras from the past couple of administrations. So in 2017, the American Health Care Act was defeated. And if it had passed, here's what it would have done. It would have repealed the individual mandate and the employer mandate for health insurance. It would have dramatically cut Medicaid spending and eligibility, which is very scary for our state. It would eliminate tax credits for healthcare costs, and it would abolish some taxes on high earners for some reason. I'm not sure why that's in a healthcare bill, and it would alter rules concerning pre-existing conditions and essential health benefits. So if you refer to the RAND report that's part of your reading, this was widely seen as tax breaks disguised as healthcare reform, and that's why it didn't pass. They tried to put through other very similar versions of it, and they all failed. Better Care Reconciliation Act of 2017, the Obamacare Repeal Reconciliation Act of 2017, and the Healthcare Freedom Act of 2017. Those all did not pass. So now let's talk about a bill that did pass, the Inflation Reduction Act, which was not a healthcare reform bill, but it belongs here in us talking about healthcare reform eras because of some of the provisions that were in it. It'll probably go down as one of the most aggressive climate change legislation. I don't know, this will probably fly under the radar at some point. But we'll talk about some of those reforms that were embedded in the bill. Most of them are related to prescription drugs, so we'll just focus on that. Number one, the monthly cost for insulin will be capped at $35, and that's a savings of $734 million in Part D or $27 million in Part B if those caps had been in place in 2020. Number two, out-of-pocket costs for vaccines covered under Medicare D, they'll be eliminated. So no more out-of-pocket for vaccines. That includes shingles, Tdap, hepatitis A and B. That has already resulted in $234 million in savings for Medicare Part D recipients. And number three, oh, that's right. How could I forget about this? On that previous slide about talking about, how much spending will be in the future. I'm sorry. I apologize for my dogs. Okay, so when do you reach the catastrophic out-of-pocket spending phase? It's $8,000 this year. In 2025, next year, it will drop to $2,000. I will double check that for accuracy, but it's in my notes, so I'm pretty sure it's true. And finally, on September 1st of last year, the administration published the list of the first 10 prescription drugs that they are now able to negotiate for. So up until this point, you had to just, Medicare could not negotiate with the pharmaceutical companies. We had to pay whatever price tag you put on those medications. And that has resulted in being gouged, to say the least. If you knew what some of these medications cost, it's awful. All right, so those negotiated prices will go into effect beginning in 2026. So it's quite a while before we'll actually see the change, but that is a huge step in the right direction. Alrighty, so we have talked about the history of our policy, of how how medicine as a field progressed, and how we pay for things, and attempts at reform in this country. And now we get to the end of the lecture, and you have to answer the question, so what, right? Like, I'm a nurse. Where is my place in this? What is my role? So when it comes to these policies, it's not just important to know what the policy is and how it's made. It's important to know how to influence its creation or change, how to influence the change, how to contribute to your healthcare world in the political arena. Nurses, we are huge numbers, and we can really act as change agents in an individual and in a collective manner. So for the most part, when we're talking about the federal level, it is in the collective where we are the strongest. Coalitions, political action committees, most of your organizations have lobbyists. I don't know if you know this or not. The American Association of Nurse Practitioners, they have lobbyists. The American Nurses Association, they have lobbyists. So whatever your organization's agenda is, they have a lobbyist in Congress working on that, right? So that's it's a very basic, very rudimentary introduction to it. We're going to talk about it in much greater detail down the line, but it's just to understand the power that you have in numbers, right? So you want to stay educated and stay on top of the policies that are happening in your hospital, on your local level, state level, federal level, and get involved in the ones that you want to have some sort of influence on, either in a personal or professional level. So this concludes the first lecture here in international healthcare policy. So again, I'll remind you to do that Google search on the impacts of the Affordable Care Act. Give me 3 to 5 sentences, or longer if you wish, on what you found. And I can always be reached for any questions that you might have, and have a great week.